That essentially also ties into the therapy-related leukemia concept. But what we investigated in that research is that we don't know much about the impact of clonal hematopoiesis on outcomes of ALL. So if you think about the biology, ALL is quite similar to AML with the fact that it arises from a hematopoietic stem progenitor cell, and clinical presentation is quite reminiscent of acute myeloid leukemia. And when you look at the mutation spectrum of ALL in older adults, it actually overlaps a lot with the myeloid neoplasms. So this is something that wasn't fully appreciated before, because most ALL genetic studies, genomic characterizations of ALL comes from pediatric literature, or young adult literature at best. But when we really focus on adults above age 40, we see that majority of them have myeloid mutations. So in our cohort, 1/3 of adult ALL patients had either a p53 mutation or a non-p53 myeloid chip mutation. This is in genes that we associate frequently with myeloid neoplasms and chips, such as DNMT3A, TET2, ASXL1, spliceosomal mutations, so on and so forth. And interestingly, patients who have myeloid mutations have inferior outcomes compared to patients who don't have these myeloid mutations in the same genetic risk group. For instance, patient is PH-like ALL or other known genetic subtype of ALL. These myeloid mutations predicted worse outcomes. So we then started to investigate the mechanism here, and we hypothesized that perhaps if they have these myeloid mutations as dominant clones in their ALL, they might have had this mutation in the chip form for several years. So we went back and studied the hematopoietic tissues from these patients obtained years before they developed ALL. And most of these patients had therapy-related ALL. Therapy-related ALL is enriched for myeloid mutations. And when we studied multiple patients who had ALL after multiple myeloma, we looked at their marrows, for instance, 5-6 years before ALL. Their myeloma was in remission, but they were getting surveillance marrows, and we had leftover samples or DNA. So we could actually identify the mutations, p53 mutation or DNMT3A or TET2, years before they had ALL. And then this clone, this chip clone, acquired the additional hits to drive that ALL. So we showed that chip can actually be a risk factor for ALL in adults, much like it is a risk factor for myeloid neoplasms. So this obviously opens perhaps an opportunity or more research questions towards prevention. For high-risk individuals, can we track clonal hematopoiesis while they're getting these genotoxic therapies or lenalidomide? And when we identify CHIP and we start to see these patients in CHIP clinics everywhere in the world, we will need to think about ALL as a risk as well, for which we don't have any tools at the moment to prognosticate patients. And then what can we do to perhaps prevent progression of these clones to ALL is going to be the next set of questions.